Thank you very much, Christian Gadd. Dear friends and colleagues, it's a real pleasure for me to be in Israel and to have the opportunity to make Christian less irritated. I have two messages. One is you should use high sensitivity troponins. They fulfill the guidelines, 99th percentile, 10% CV. We must use them. The challenge is what cut point? That's the first message. Second message is that when we're diagnosing myocardial infarction, we should look for a change because we're going to find high sensitivity troponins in everybody. We have data now that if you're male, they're present in 37% of the normal population. If you're over 60, they're present in 58% of the normal population. So you have a background. It's a background like renal failure. Everybody has them, and I'll discuss some of the mechanisms as to why we're getting troponins found in the blood when we always thought that they only came from myocyte necrosis. Everybody has elevated troponins if we have a real sensitive test. And the challenge is how to identify clinical syndromes and to make the diagnosis of myocardial infarction. And we have to look at a change, just like we've been doing for a long time in renal disease. It's not a particular challenge. These are my disclosures. So even small concentrations are going to occur in the normal population. The consensus statements, and there have been several, I'll focus a lot on the universal definition of MI, and several of my colleagues here, Christian and Keith Fox, are on the various committees. And we defined you've got to have a 99th percentile. I'll come back to this several times. We've stated this very clearly, and just the discussion that we've had now, people don't listen to guidelines, and we've heard some of the reasons. And then we should have a laboratory precision that the coefficient of variation should be less than 10%. So if you repeat the test, it's only 10%, less than 10% different. Very low levels are expected, and it's critical that we evaluate change to distinguish acute situations from chronic situations. Now, it remains true that any elevation, and no matter what the setting, it denotes a worse prognosis. And that's true of high sensitivity troponins. It's very clear they add to our prognostic information, very clear across normal populations, across elderly patients, and in ACS. Data is in that they add to prognosis. Now, the challenge, of course, is that there's many causes, and I have two slides here, and you know them all. Congestive heart failure. What about atrial fibrillation? What about marathon running? Very challenging when you have a person who drops down while running a marathon and the troponins elevated. Drug toxicity, of course, heart transplant patients, other diseases such as hypothyroidism. Recent reports about electroconvulsive therapy will cause elevations of troponins, and we all have clinical situations where we've seen elevated troponins and it's not yet reported in the literature, and as we try and gather more cases to make a publication. So I won't mention some of those, and because our neighbour is Australia, we love to mention snakes and spider bites. We don't have any snakes or poisonous spiders in New Zealand, but in Australia, along with other things that are undesirable, they do have snakes and spiders. Now, I have an editorial coming out this month in JACC. We've had a mantra, including the universal definition of MI, that it's always caused by myocyte necrosis, that it doesn't come from any other reason. And of course we know that's not true. We see the marathon runners, we see the patients with fast SVT. ECG is normal, there's no ischemia on the ECG, and yet the troponins go up. And they go up very early. And we know that if there's myocyte necrosis, that the contractile proteins continue to degenerate and the levels stay up for 14 days. They don't go up and down in 12 hours. The half-life of troponins is 4 to 8 hours. And so if you've just got troponin release, it should go up and down if it leaks through the membrane. If there's continuing damage, then the levels will stay up. I've called them types because I like types from the universal definition, but of course it can create some confusion. Apoptosis, normal myocyte turnover, cellular release of proteolytic troponin degradation products, increased wall permeability, and formation and release of membrane leaks. So this is a classic study. It's a very nice study, animal study. It's the only study really, in my view, to show that if you have myocyte necrosis, then you have elevated troponin. So these are from various animal specimens. It's been strained, in this occasion, for troponin I. And if it's not there, the cell is necrotic. It's leaked out, it's gone. If the cell was viable, the troponin is still there. So this proves that necrosis is related, in my view, to troponin release, necrosis of the cell. What about apoptosis? Well, we have prolonged programmed cell death, and there's animal studies to show that apoptosis causes the release the cleavage of proteins so that they're smaller. Troponin is a large molecule. It won't come out through a viable membrane. The membrane has to be dead, we think. There's normal myocyte cell turnover, very nice studies related to nuclear bomb experiments in some cases, and in some cases worse situations. And it's defined in the DNA. We have about a 1% annual turnover of our cells. So our myocytes are turning over, which is something that we didn't understand until a few years ago. And indeed, through your life, 50% of cells are exchanged. We don't know whether such low-grade turnover results in relief of troponin. I've always wanted to write an editorial which is called We Can Now Detect Apoptosis with High Sensitivity Troponins, and I just hope that Keith doesn't beat me to writing that editorial. Cellular release of proteolytic degradation products, quite a bit of data and experimental literature that if a cell becomes ischemia, for example, 15 minutes of ischemia, there are troponin degradation products released from the cell. And it should be easy to identify these and distinguish some of our clinical situations, SVT, rapid AF, and so forth, whether this is one of the mechanisms. Increased cellular wall permeability, animal data showing that this may happen, in particular in relationship to stretch. Stretch is a very important mechanism, and if you get stretch of the myocytes, then troponins will leak from the cell. And that may be part of the mechanism with the marathon runners. And in a rat model, increasing the preload, you get release of troponin I, independent of ischemia. So you can see the situation in heart failure, that one of the mechanisms may well be to do with stretch. This last one is very hypothetical, never been shown clinically. There's a whole literature about blebs being formed in the liver, and they can encapsulate cellular content, and the blebs get released into myocardium. And they've actually shown that these blebs occur in cultured myocytes. So never shown in man, but in cultured myocytes, and you can see here that it's rather impressive that there are these blebs that occur, and potentially that could be a mechanism of troponin elevation. So you can see it's extraordinarily challenging. What's the evidence about low levels? Well, there's a lot of evidence, and this here, you'll be very familiar with the tactics trial. The cutoff for troponin T is 0.03. That was the 10% CV. It doesn't fulfill the 99th percentile. But the tactics, David Morrow led this, investigators went down below 0.03 to 0.01, so you could detect it. But the variation at 0.01 is about 14%. So the data could be invalid. But you can see that there's a very clear relationship with the advantage of invasive therapy if your troponins are elevated above 0.01. So we have data, given the caveats, that if you go down below the current cut points, that intervention will reduce death, myocardial infarction, and revascularization by 100 events per 1,000. So it's not, as we'll see in some of the other presentations, 3 events per 1,000. We're talking about 100 events per 1,000 if you have this cut point. The PEACE trial, I can't cover all the literature in the time, is an important trial. It was like the HOPE trial, looking at whether ACE inhibitors reduced cardiovascular death, MI, and stroke, an endpoint that is used most commonly. I present it because it may have muddied the water, and it's extraordinary because when I read this paper, there was no relationship to myocardial infarction. And my bias, we all have biases, is that we're rupturing plaques all the time, and we should have thrombi, and we should have myocyte necrosis, and high sensitivity troponins should detect that. But in the PEACE trial, that didn't happen. And so I contacted the PEACE investigators, Mark Pfeffer, and I said, what was your definition of MI? Wasn't in the New England paper. I didn't get to write a letter within 2 weeks, which I think is an extreme requirement. What was your definition of MI? It wasn't in the New England Journal of Medicine paper, nor was it in the PEACE design paper. And Mark said, actually, I don't know. I'll get back to you. It took some time to get back to me about that definition. Very important, the definition they used. 11% of patients had high sensitivity troponin, so this is a high sensitivity troponin over 14, which is the 10%, 99th percentile. Levels were associated with various things, and this is what they found on the multivariate analysis. Very interesting that high sensitivity troponins, so this is a high sensitivity troponin, predicts cardiovascular death and predicts the development of heart failure. And we don't, at least I don't, understand that. So it's predicting you getting heart failure in the future. But it didn't predict myocardial infarction. Hazard ratio 1.16, but didn't depict infarction, didn't predict it. And other data sets have shown that recently, but I think it's related to this, and it's extraordinary, really, that the reviewers didn't pick this up. But the definition of MI required twice a cut point, which is outrageous, really. It's used commonly in the States still, but it's 3 times higher than what it should be, 0.03, and then they doubled it. So really, I think those data should be questioned. Now, the Dallas Heart Study is a very important study. It looked at normal population, and with contemporary troponin, they found that 0.7% had elevated contemporary troponins in patients with hypertension, LVH, diabetes, Some of the elderly, atrial fibrillation, they were more likely to have elevated troponins. Well, recently they looked at high sensitivity troponin T, and they found 25% of the same population had elevated levels. They're related to the same factors as before. As I mentioned, if you're a male, it was 37% of the patients, and if you're over 60, it was 58% of the patients. So a lot of people are cruising along with high sensitivity troponins. Some of those mechanisms may be invoked. It may be apoptosis, or it may be rupturing plaques, or probably things we don't know about. And when they looked at the levels, so this is a 99th percentile. Clearly, if you're above that, your outcome defined here as overall death over 6 years, your death rate is 29%. So community just cruising along, 29% dead in 6 years if you have elevated troponins above a high sensitivity cut, which is about a sixth of the contemporary level. And then if you go way down, this is where it gets detected, about 3 units. The mortality is 1.9%, 2% mortality. 1 in 50 of you are dead in 6 years if you have a barely detectable high sensitivity troponin. So really extraordinary data. And then this data you'll be very familiar with, New England Journal of Medicine from Basel, where they looked at 4 sensitive troponins. The terminology is very important. Only 1 high sensitivity troponin, and they compared the results to the standard assay. And these are AUC curves, and you see these 4 tests were all better than contemporary troponin for defining the diagnosis of MI. So how do you diagnose MI? You look at the ACC guidelines and you get a couple of guys to look at the patient. But of course that's rubbish, isn't it? Because I've just told you that to define an MI, you need a rise and or fall. And they didn't do that in the study. But you can see that these tests are better than the standard test. And if you looked at within 3 hours, are substantially better with the shift of the curve to the left. And if you look specifically within 3 hours, you really see that the contemporary high sensitivity troponin T, which is a very good test, is really useless at defining MI on this basis. Now this is one of my most important trials. It's a higher sensitivity troponin T test where they looked at stored blood, patients with ACS, about 100 patients, and they looked at the levels on admission of the contemporary levels, and they looked at this higher sensitivity troponin I. And when the patients hit the ED, 60% of them had elevated levels. Now this is critically important for improving patient care. The theme of my talk is that high sensitivity troponins will improve patient care. And you can detect when patients hit the emergency room whether they've got an elevated level. And then you can look at change over 3 hours. And I would submit that those patients can get better evidence-based care, including rapid triage to the catheterization room or early discharge. So very important slide. And this is data that I have the pleasure of presenting from Keith Fox's group. It's always a challenge to present something before the following speaker, because he can say, you got it wrong. But Keith's my good friend, and I know he won't do that to me, but it's a possibility. So they used a higher sensitivity troponin, a modification of the Abbott assay, which was improved. And the important point I'd like to make is that they had a validation phase, 1,000 patients, and then an implementation phase, 1,000 patients. In the validation phase, the clinicians did not know the results of the higher sensitivity troponin. And so here it is, the validation phase here, we're using a cut, which was a 10% CV. not the 99th percentile, but a 10% CV. And the patients who were in this phase, 40% of them were free of death or recurrent MI out to a year and a half. When they let the clinicians know that the higher sensitivity troponins were elevated, the outcome for death and myocardial infarction was substantially improved. Only 20% had the event over a year and a half, but very high numbers, of course, for a higher sensitivity troponin. Why is that? Because the clinician said, hey, these guys have got higher sensitivity troponin, I'm going to give them aspirin, I'm going to give them beta blockers, I'm going to give them clopidogrel, I'm going to give them ACE inhibitors, and I'm going to give them statins, and I'm going to get their LDL down. And the patients did better. So if you measure high sensitivity troponins, the patients are going to do better because they're going to get evidence-based medicine. Now, there's a lot of confusion as to what a high sensitivity assay is, and there's a few guys making up definitions and getting it published here and there, like the good European Heart Journal last week or so. But Apple, who's really a premier person in this area, defined a scorecard in ClinChem as to what troponin assay should be designated. So there's 22 of them, and essentially 16 or 17 are useless and should not be used. And I think Cardiac Society should have been much stronger in making that sort of statement. But he defines, as I've told you, about the international imprecision at the 99th percentile, and whether it's guideline acceptable, clinically usable, or not acceptable. So these are the 18 or so which are not high sensitivity troponins. So none of these are high sensitivity troponins. And just to point out that the one that I showed from Scotland about the Abbott test, it's a modification. It's clinically usable, but it's not high sensitivity. And you'll see that there's only very few of these, some of them experimental, that are guideline acceptable. Most of them are not guideline acceptable and should not be used, in my view. And there are only 4 high sensitivity troponins. And the one that is used, of course, clinically is, sorry, I just need to figure out how to go back, is the troponin high sensitivity T, which we've been using clinically in New Zealand for over a year in all of our hospitals. So we're banned in contemporary T and use high sensitivity troponin. So I've said it'll improve patient care. Why is that? Because you get improved diagnosis, you get earlier diagnosis, you get improved risk stratification, and there are other evolutions such as monitoring antimitotic therapy. You can detect that the troponins can go on up. If you don't use them, you're going to get misdiagnosis, you're going to get mistreatment, you're going to get lack of evidence-based treatments in patients who may benefit. You give inappropriate advice about driving. One hospital is using a useless troponin and will be diagnosing infarct when it hasn't occurred, and vice versa. Inappropriate stress to the patient, et cetera, et cetera. And bad care, of course, leads to increased costs. So this is what we said on the universal definition. You must have a setting of ischemia, and you need a rise and or fall. We never defined that. We defined a rise and fall as 20% for reinfarction, and other groups, the biochemical groups, defined a rise and fall of 20% in renal failure. But we never defined it in the guidelines, and you'd wonder, you know, we can't see the wood for the trees, elephant in the room or so forth, must have a rise and fall, but nobody said, hey, what is that? Well, I think it should be 20 with the contemporary levels, and it should be 50 with the new level. So rise and fall, troponin, and evidence of myocardial ischemia, and CV less than 10%. Now, an important concept is biological variation. If you can measure something in everybody, such as a hemoglobin, you can talk about biological variation. You can't if it's BNP. Can't measure it in everybody. But we can do it with troponin. And so now we have the opportunity of looking at intra-individual variation over time and within 4 hours. And my third very important point is that the important metric is intra-individual variation within a short period, like 4 to 6 hours. That's extremely important. You'll see a lot of confusion about this. So when a patient comes into hospital, he has baseline elevated troponins, and we want to know what happens normally in the next few hours. Well, what we know, and Catus has some data online in ClinChem as we speak, just came out online yesterday. What is important is the individual variability. And in general, it's always been less than 50%. We found in New Zealand that it's about 30%, and here's some data that I've shown you. Now, this paper in ClinChem purports to say it's something like 80%. Well, it's not correct. What they've done is they've mixed various data sets, and they use different things. Here's the inter-individual variability, short term, and it's 48%. And of note, when you look at these data sets, the cut point is normally 14, and they're looking at changes below 14. Often, and these are individuals within the study. So this goes up to 6, and there's changes under 14. But when you look around 14, the changes is much less. So I defined a criteria based on the data that was available, which said that we should have a 20% change if it's contemporary, and it should be 50% if it's under that. And I'll just skip lightly. We've done a study in New Zealand looking at this, and the best criteria were those criteria that the specificity was 95% and the sensitivity 90%. And so this is what we've been using nationally for a year. So patients come into the ED. Of course, you divide them into 3 groups. It's not ischemia. They go somewhere else, get discharged. It's clear ischemia, and you do high sensitivity troponins. It's atypical ischemia, no ECGs, you do high sensitivity troponins. And then we have this algorithm, which may appear complex at first glance, but if you're above what is the contemporary level, above 53, you retest in 3 hours, and if the change is more than 20%, that's a myocardial infarction. A universal definition, we're meeting in a few days' time to discuss some of these issues. If it's less than 14, you're coming down this pathway, test again at 3 hours, and if you get a 50% change, then it's myocardial infarction. And we can couple that to a more complex algorithm, which I won't go through, but if you have myocardial infarction, then you apply evidence-based medicine, and you go to the cath lab, and you find the unstable plaque, and you stent it, and you put the patient on high-dose atorvastatin, etc. So clinical practice, it's challenging, but I think we should face it and not run away from it. I think we should look at change, 50% if it's less than contemporary levels. If they're between 3 and 14, something's going on with the myocytes. I've written here myocyte necrosis, but you appreciate that that's a shorthand. And if it's a non-ischemic setting, then we should look for other causes. And we know that in pulmonary embolism and renal disease and pulmonary disease, intensive care, diabetes, etc., that if you have elevated troponins, you do worse. And of course, it's challenging to us as to how we should treat that patient. So just in the last couple of slides, we need to confront this in our guidelines. It'll be difficult to get consensus, and the universal definition, I think it's fair to say, has always been ahead of the group, and that's challenging. We haven't always taken the group with us. And there's a couple of things we'd like to do. We're going to keep using the different types of infarcts. We're going to discuss how to drill down on type 2 and its challenges. We will divide type 1 into two types. I think it was an admission that we didn't say type 1A is STEMI, and that means reperfusion, and type 1B means non-STEMI. And then we need to talk about PCI. And my view is that we should use the same cut points that we're using now. So you use high sensitivity troponin, much better test, but you use the same cut points. And my view is you should actually add other information, as we're doing in the ischemia trial, that we add symptoms or ECG changes, 0.5 millimeter depression, or something going on angiographically, and we'll talk about heart failure. Should we use MRI as our diagnostic criteria? I've just written an editorial with a colleague from Mayo Clinic. We think not. The pathophysiology of ACS is multiple emboli secondary to plaque rupture. So you have emboli all over the place. And MRI does not pick that up. It picks up about 1 gram of confluent myocyte necrosis with the enhancement imaging. So I think the gold standard is actually high sensitivity troponins. We've got data evolving about cutoffs, sensitivity, specificity, rise and fall, and it fulfills the definition of MI. So I think the criteria should remain troponins and high sensitivity troponin. So my second to last slide, this will be challenging. We'll have increasing numbers of MIs. Keith's very nice work showed a 29% increase using just one cut point. When we use the rise and fall, the increase of MI is 3%. We're not going to be flooded with a lot of MIs. It actually cuts out some of those other causes. There'll be more confusion, but I think it'll be better for the use of evidence-based treatment, and it will result in better patient care. Thank you very much.